Yes, please start.
Good evening, everyone. Today, I'll be doing my case presentation on the topic Central Retinal Vein Occlusion with Macular Edema. Myself, Dr. Anjil Gupta, I'm a primary DNB resident of Sankara Hospital, Kanpur. The moderators for today's session are Dr. Ashok K. Sir from Sankara Hospital, Guntur, and Dr. Pradeep Sagar BK Sir from Sankara Hospital, Shimoga. Moving on with the case presentation. The patient is a 60-year-old female homemaker, a resident of Oraya, Kanpur, which presented to the hospital with chief complaint of diminution of vision in right eye since last 1 week. History of presenting complaints. Patient was apparently all right 1 week back, after which she experienced sudden painless diminution of vision in right eye for both distance and near. Patient also had history of gradual painless progressive diminution of vision for left eye, for which she had been already diagnosed for cataract 6 months back. There was no history
Anjali,
of...
just 1 minute, ma.
Yes.
With this presentation in mind, just as you come across the patient, since you have asked the leading history, so would you like to think anything in your mind with this history? Like with those history, whatever you have told, in the right eye, there was a sudden painless loss of vision since 1 week.
Yes, sir. Yes, sir. So few differentials can be taken consideration depending upon the history, which is retinal vein occlusion, arterial occlusion, retinal detachment, or vitreous hemorrhage, CSR.
Okay, ma. Yeah. So that is regarding the right eye, no, ma?
Yes, sir, for right eye.
So anything, because there is a complaint in the left eye also, do you think there is anything which you can consider based on the history in the left eye also?
So cataract, there can be glaucoma also, or
okay. Yeah, with this, why I stopped you there is ARMD also sudden, slowly the vision can decrease, true. So before going on with the case, when the patient comes and sits in front of you, with based on history only, you can arrive at a probable differential based on that history. So with that things in mind, you can go forward. And in history, this might give you an edge to ask few leading questions also. That was the intention of me stopping that you at that point. Okay, ma, carry on.
Yes. There was no history of any recent ocular trauma, floaters or flashes of light, any curtain falling sensation, strenuous coughing, intense vomiting or straining, headache, any transient loss of vision, or any similar episode in the past or in the other eye.
1 second, Dr. Anjil.
Past medical history. Patient is...
1 second, Dr. Anjil.
Pradeep, the voice is low, Pradeep. At least the voice is not very loud.
Okay. It's still, is it very low, sir?
It is low, Pradeep.
What I was trying to ask is like Dr. Anjil, like
yes, sir.
About certain negative history, right? So what was the reason of asking all these things? For example, you asked about history of trauma. So you say that it's a painless vision loss since the past few days. Yeah. So like if it was a trauma related visual loss, like would you expect that the patient could not have any pain? Is it possible?
So sometimes if it's no,
what I wanted to convey is like just go by a few set questions for negative history. Your negative history should be corroborating with what you are thinking in terms of what is the possible diagnosis you have in your mind, what are the differential diagnoses you have in your mind. For that, like you need to ask. For example, you can ask about like you told like you have the following differential diagnosis, whatever you told, arterial occlusion, vein occlusions, and you just told only these two, but to be like, you have to always think from cornea to optic nerve, then you will not miss any of the diseases, like whether there are any corneal conditions which can lead to something like this, whether there are any conditions which can be in the vitreous, then in the retina, in the optic nerve. If you think in that way, you would not miss anything, because you would even consider a diagnosis of ischemic optic neuropathy also in this case, correct? But you
Yes, sir.
would consider it if your mind is occupied with your preoccupied diagnosis of vein occlusion. So it's a sudden vision loss. So regarding that, you need to ask. For example, if you had a diagnosis of ischemic optic neuropathy, you could specifically ask for at what time of the day the vision loss he noted, whether it was just when getting up from the bed. So your negative history should correlate with what you are thinking, what diagnosis you have in your mind. So you have to have an open mind when approaching any case. Don't be in a opinion that this is a case of central retinal vein occlusion. Always keep an open mind and think from there. So you could probably, then you will probably, yeah, I agree that why you asked for floaters, flashes of light, cut and falling sensation. This is for what reason you asked?
So for retinal detachment.
Correct. You asked about retinal detachment. And what is the next one? Sternus, coughing, intense vomiting.
So PH may occur if there is sternus coughing or.
No, what is that we describe about when if a patient develops a vitreous hemorrhage, not commonly vitreous hemorrhage, it would be usually a subhyaloid hemorrhage or sometimes even a subinternal limiting membrane hemorrhage following a sternus, coughing, intense vomiting. What do we call it? Okay, Valsalva retinopathy. Okay. You got me? Can you hear me?
Yes, sir. Yes, sir.
Valsalva retinopathy. So whenever you are talking about any negative history, you should have that thing in your mind, like, okay, why I am asking this negative history? So, and again, when you told about sternus coughing, definitely there will be a question regarding Valsalva retinopathy. So you should be knowing about it when you mention. In exam, it's also sometimes that like you lead the examiner to ask you questions by your whatever words you use. So whenever you are talking about something, you always have to be very sure that you know about that. Okay.
Yes,
So
sir.
why?
So sorry, I cannot hear you.
Why headache? Why you are worried about headache?
So
About headache.
papillary edema can also cause sudden loss of vision. So that's why.
Sudden vision.
Seriously,
And
Dr. Anjali,
hello.
papillary edema can papillary edema can. Does papillary edema cause sudden loss of vision?
No, sir, it does not cause sudden loss of vision.
That's what, ma. Before you are about to answer anything, please think twice, because they will ask. Suppose a patient with papillary edema comes to you in the initial presentation, will he complain of what generally his vision will be? If you would have seen a case, you would have understood. There will be a gross reduction in vision.
Yes, sir. No, sir, there will not be any gross reduction in vision. It will be around.
That's the exact thing I was telling, why I stopped you and told about leading questions. Pradeep sir is telling you regarding each one. So it should be very specific, ma.
Yes.
So in what what sir and I was trying to tell is, like, in papillary edema, you usually get vision loss when it is in the chronic stage or in late stages, like post papillary edema optic atrophy. In early stages, there will be no visual loss. As such, the patient will not come with visual loss, and particularly in this situation, it's a unilateral vision loss. And again, papillary edema is bilateral, and if there was a complaint of gradual vision loss in both the eye, then if you consider papillary edema as one of the differential, that is still fine. But with an acute vision loss in one eye, if you want to think of an optic nerve condition, it would be probably like ischemic optic neuropathy or an optic neuritis. But the age is not very like common for optic neuritis. Like whatever you are talking about, the age being in 60s, it is less likely to be optic neuritis. So you would even consider an ischemic optic neuropathy in this scenario. So your negative history should be helping you to move towards a diagnosis. It should not be random negative history that you just mention for any other. It should always lead you to one particular diagnosis, or you should be trying to rule out one particular diagnosis.
Yes, sir.
Yeah, continue.
Past medical history. Patient is a known case of diabetes mellitus and hypertension since last 1 year and has not been compliant to her medications. She is not a known case of any cardiac disease, liver disease, or any other systemic diseases. Coming to past surgical history, patient had a history of cataract surgery in right eye 1 year back elsewhere, after which her post-op vision was satisfactory. Personal history. Patient follows a vegetarian diet. Her appetite is normal. Bowel and bladder habits are regular. Sleep is regular, and patient has no history of any addiction. There's no coming to family history. There's no family history of glaucoma or any other significant family history. General examination. Patient is well built and nourished. She is conscious, alert, and well oriented to time, place, and person. Her pulse rate is 80 beats per minute. BP was 160 by 180 millimeters of mercury, and her respiratory rate was 16 per minute.
I think you have written.
Coming to ocular.
No. It's 160 by 100 is what you've written now. You told 180.
And don't get tense. Like this is just for a learning purpose. You need not really get too much. Okay.
Yes, sir. Sorry, sir. BP was 160 by 100 millimeters of mercury, and respiratory rate was 16 per minute. Coming to ocular examination, head posture was erect, forehead and facial symmetry was maintained. Visual axis for both eyes were parallel to each other, and extraocular movements were full, free, and painless in all direction of gazes. Coming to vision, her vision for right eye was 6 by 36, which was improving to 6 by 12 with +1 cylinder and -0.7, +1 spherical and -0.75 cylinder at 80-degree axis. And for left eye, her distance vision was 2 by 60 with no improvement with pinhole. And her near vision for right eye was N24 and for left eye was less than N36. On slit lamp examination, her eyelids were normal, conjunctiva and sclera were normal, cornea was normal in size and shape, sheen and transparency was maintained, and in right eye, a temporal scar was seen at limbus, measuring around 3 mm, and corneal sensation were preserved in both eyes. Anterior chamber was deep, Van Herrick's 4 according to the Van Herrick's grading, and quiet in right eye and Van Herrick's 3, and quiet in left eye. Iris was normal in color and pattern, and there was no evidence of neovascularization of iris in both the eyes. Coming to pupil, pupil was 3 mm, round, central, and reacted to direct and indirect reflex, and there was no evidence of RAPT in both the eyes. Lens, in right eye there was a posterior chamber intraocular lens implanted, and in left eye there was a cataract of grading nucleus sclerosis 4 and posterior subcapsular cataract grade 3. IOP measurement that was done by Goldman applanation tonometry, which was 22 millimeters of Hg at 2:20 p.m. and 9 for right eye, and 19 millimeters of Hg at 2:20 p.m. for left eye. In gonioscopy, for right eye, angles were wide open. It was graded according to Schaffer's grading, and it was wide open in right eye, and in left eye it was open, and there was no evidence of neovascularization of angle. Coming to fundus examination, on distance direct ophthalmoscopy done at 1 meter, there was a red glow present with no media opacities for right eye, and For left eye, there was dull red glow, and for direct ophthalmoscopy, media was clear with medium-sized disc seen with obscured margins, and for left eye, media was hazy due to cataract. Coming to fundus examination, media was clear, disc was mild hyperemic disc, oval in shape, margins were obscured, vertical cup disc ratio was 0.3, and multiple flame-shaped hemorrhages were seen at the disc and parapapillary region. Blood vessels were arising from the disc, branching dichotomously with AV ratio of 1:4. The veins were dilated and tortuous, and severe arterial attenuation was seen. In macular, FR was absent. Multiple hemorrhages and retinal elevation within 1 disc diameter from macula were seen, suggestive of macular edema. Multiple flame-shaped and dot and blot hemorrhages were seen in all 4 quadrants, and there were few area of tessellations present. In left eye, media was hazy, but retina appeared grossly normal. This is the Amsler-Dubois charting of the case, where we can see these are the flame-shaped hemorrhages distributed in all 4 quadrants around the retina. These are the dilated tortuous veins. Dot and blot hemorrhages were also scattered around all the 4 quadrants, and there was macular edema seen. A provisional diagnosis for the case is for right eye pseudophakia with non-ischemic central retinal. So you're not audible, sir.
Hello, can you hear me now?
Yes, sir.
Yeah, like can you go back to the diagram? So when you write a fundus diagram, like it should always include a few things. One is like, okay, if you are not mentioning the name of the patient to prevent the privacy for the privacy of the patient, that's fine. Age and gender is fine. But there are other things like whenever you draw a fundus diagram, you always mention at time at which you have drawn, because like particularly this becomes relevant in retinal detachment, because you would have drawn on one particular day at that particular time, and if the patient is seen later, there is a possibility that there would be worsening. Okay, so it would be only a superior detachment, and you would have drawn a superior detachment, and by next day it would have even extended up to inferior quadrant. That's possible. So whenever you draw a fundus diagram, always mention the date and time at which you have recorded the findings. And it's always better to write your name and signature to say that like who is the person who has charted this diagram. That is one thing. And regarding ora serrata, you have mentioned like how is it represented?
So it is represented in brown color, like.
Yeah, correct. Some people prefer black and some people prefer brown. I would not say that this is right or this is wrong. Like each book has a different description. That's fine. But is it present only in the nasal retina, or it will be present even in the temporal retina?
So it's present in the temporal retina, but it's very widely spaced in the temporal side. So
what do you mean by spacing? What is spaced apart? Okay, what is that you see in ora serrata? You see that U shape, no? What is that?
yes.
What is that?
So the projections of
what are the projections?
What are those projections?
So the uveal projections in the retina which we see.
No,
They have
not.
a name for it, ma. But yeah, that is okay. But do they have a name for it?
You would have heard, no, dentate process and oral base.
Process, huh?
Okay.
The dentate process and oral base are more prominently seen in the nasal retina. But that doesn't mean it will not represent ora serrata all along. Ora serrata, it should be represented at the junction of retina and pars plana, which corresponds to the second ring what you are seeing over here, the second circle. We also draw on the temporal side, but we don't show these oral base and dentate process prominently. We do show that this is the area where it is ora serrata. So we do draw it almost 360 degrees, but we make sure to show the oral base and dentate process more prominently on the nasal side, because temporal side it is less prominent. The second thing is like you have written the optic disc, the location of the optic disc. If you see, like what is the like where should be the optic disc drawn in Amsler's Dubos chart?
So we draw it approximately 2 disc diameters away from the macula and a little bit upward, then where we draw the macula.
So usually
what
fovea. Where we draw the fovea,
that's what you draw the disc, then draw the fovea. You're talking reverse.
Okay. So we should draw a disc first.
Yeah. You can attempt to tell. You are trying to tell, you please tell.
So first we draw macula at the fovea at the center, and then we go 2 disc diameter nasally, and then there we draw the optic disc.
But the 2 disc diameter is something which is your decision. No, you can write a larger disc, you can write a smaller disc, but there is one general guideline as to where you have to write the disc. There we write the disc. If it is larger, we show that it's a large disc, and if it's smaller, we write it as a smaller disc. But by convention, like we actually have a one particular point in which we draw the disc, which is a vertical line. You can see that there is a 1 and 5 line, you can see, no?
Yes, sir.
Like the Roman letter 1 and 5, you can see a vertical line which meets these. Yeah. So exactly in the center, like along the horizontal, where the the 3 and 9 is there. So in that horizontal line, at the intersection of this horizontal line and the imaginary vertical line which joins this 1 and 5, that's the position where we usually draw the disc. Okay. So it's not that you don't have a set 2 disc diameter. You can't measure the 2 disc diameter, right? Based on what disc size you mention here, we assume that, okay, from here, this is the disc size, that is what we assume. So it's not that we don't have a specific point. It's at this intersection of these 2 lines, that is an horizontal line and a vertical imaginary line, which is passing through that ends of 1 and 5th line. Okay. So that is the place where you draw the disc. And regarding the background, you have mentioned like you have painted the entire background with red, correct?
Yes, sir.
Yeah. By doing so, what you are trying to indicate? Why is it drawn as? Why it is shaded with red?
So to show that retina is attached where.
Yeah, true. But this is something which some of the books recommend is like we have to indicate that the retina is attached in patients who have retinal detachment. For example, if it's a temporal detachment, the temporal part you will shade it with blue and the nasal you shade it with red to indicate that this is the attached part of the retina. Whereas in a completely attached retina, we need not shade it completely with red because it doesn't allow other color coding to be shown on it. For example, in this, here what you have made is like a darker red to show the hemorrhages you have done. That's good, but still, like this is something which again, like everyone may not agree. Some of the examiners may agree to shade the entire background with red, and some may not agree. This I am not telling that this is how it should be, but what is more accepted is in a patient who has a retinal detachment, the attached retina is represented with red shade, but not every case of attached retina. For example, if it's a case of like assume that you are probably presenting a case of nucleus drop. It's not that you have to shade the entire retina with red. If there is a nucleus drop and there is a peripheral detachment or there is a temporal detachment, in that case you shade the detached area with blue and the rest of the attached area with red. But it's not required to shade the entire retina with red in all the cases. In a patient who has a retinal detachment, the attached retina should be shaded with red, but the other in other cases it's not mandatory, because if you want to show some other lesions, no, it will be that red background will be obscuring them. Okay, if you want to show microaneurysms, if you want to show retinal hemorrhages, this will obscure it. You have shown it in different shades, that's good, but still, like, you need not shade it. That's what I am trying to tell.
Yes.
Sir Ashok sir, you would like to add anything here?
Yeah. Just one more thing, Dr. Anjali, go back to your description of the retinal hemorrhages, whatever you have documented, ma. It shows that the macula, the FR is present multiple hemorrhages and retinal elevation within one disc from the macula noma. I think you wanted to mention fovea, I guess. Is it what it is?
Yes, sir.
So just that if you document and write no, there is a chance for the examiner to ask. So whatever wordings or whatever you are trying to tell, please make sure that it is correct. Otherwise, they will ask you, what is this? So that is one thing. And regarding the chart, very well summarized by Pradeep sir, that it should be drawn there. And I think it is better you write the diagnosis at the bottom also. I would it would be apt, like whatever your probable diagnosis would be, and maybe the other eye also. And thing I would like to add is, as the other eye, though the cataract is dense, having a look at the fundus and whether you're really seeing the fundus or not is one more thing which is important. If not seen, there are, like, how do we go about the other eye also, we should know. So these are the things which I would like to point out now.
Yes, sir. Coming to provisional diagnosis for
And there's a
right eye.
question here, ma. Just a second, ma. There's a question from YouTube comments. When drawing the fundus diagram, what does the colors indicate? Can you elaborate on this? So when drawing the fundus diagram, so what do you draw the disc with? What do you draw the vessels with? I think that is what the audience want to know.
So we draw the disc with red color. We draw veins with blue. The hemorrhages are shown with red color, depending on what type of hemorrhages they are. And the macula is shown with red color with a cross sign, and other things which can be, if other colors which you use are green, for any vitreous hemorrhage or any vitreous opacities, or blue is also used to show detached retina. And if there are exudates or drusen's or cotton wool spots, we use yellow color. So every color has a
And
different.
to describe macular edema, you have drawn the macular edema as well with blue, I guess.
Yes, sir. To describe edema, we draw four circles to describe the edema around the macula.
And there are other. Yeah, Pradeep, carry on here. There are a few questions which they were asking. Difference between fovea and macula when presenting, and when do you say fovea and when do you say macula is also is what in the chat box there are questions about. Carry on, Pradeep.
You're telling about retinal hemorrhages. You told hemorrhages are represented with red. Is it true for every hemorrhage? Like, what about subretinal hemorrhage? What about retinal hemorrhage? What about vitreous hemorrhage? You just told hemorrhages are represented with red. So is there a difference for each level?
So intraretinal hemorrhages we show with red. For vitreous hemorrhages, green color is used to represent vitreous hemorrhage.
For subretinal hemorrhage?
So red only is used for
most of the area, most of the, like if you go by the standard notations, like usually anything which is subretinal is represented with yellow actually. Even some people would prefer to include even subretinal hemorrhage with yellow, but again, like this actually varies from like books to book and based on what you are following. So that is one thing which is in color coding. These are some of the issues which you always have, but it's always good if you have one specific reference. So if you say like this is something which I am quoting from payment, if you say something like that, then we will know that yes, you have read about it. Okay, so it's always better to quote one particular whenever you are quoting about the color coding, always make sure that you quote one specific standard book, preferably like payment is something which probably many people would accept.
this. Provisional diagnosis for right eye is pseudophakia with non-ischemic central retinal vein occlusion with macular edema, and for left eye is senile immature cataract. The differential diagnosis for my case are ischemic central retinal vein occlusion, diabetic retinopathy, hypertensive retinopathy, and ocular ischemic syndrome.
No, like these are the differential diagnosis you have after the complete examination of the eye, or was it at the end of your history or something? Like because you have explained everything, you have seen the complete retina now. So in this scenario, like would you consider other diagnosis now?
So after examining, I'll consider these diagnoses.
You still have all the 4 diagnoses in your mind. That's what you mean to say, right?
Yes, sir.
Okay, like how will you say that, how will you differentiate a non-ischemic central retinal vein occlusion from ischemic central retinal vein occlusion then?
So to differentiate, we have few points. Visual acuity is one. Visual acuity is more deteriorated in ischemics.
Do you have any
RF,
cutoff? Do you have what specific reference you are quoting here?
so it's in according to Kansky, I have read
Okay. So like Sankara given a definite like he has published the differences between non-ischemic central retinal vein occlusion and central retinal vein occlusion. Dr. Sohan Singh Hare is a very well-known anatomist. So like he has published a few differences. So it's always better if you can read it and you use them in future. But as of now, okay, you can continue with what you are trying to tell. So when you told visual acuity is worse with ischemic central vein occlusion and is better. So do you have any specific cutoff?
So usually 6/60 or less, points more towards ischemic, and RAPD is usually present in ischemic condition, and neovascularization is also seen more in ischemic condition, ischemic CRVO.
Neovascularization, when will the neovascularization develop in central retinal vein occlusion?
Is around 100, we call it 100 days to develop.
What do you call 100 days?
Glaucoma, because it takes around 90 to 100 days to develop neovascularization.
But when you see the patient, he came at 1 week, no? So neovascularization will not be a point to say, to differentiate the two. You would know that if you diagnose it as ischemic central retinal vein occlusion, you would be worried that this patient has a high risk of developing neovascular glaucoma, vascularization of iris, correct. But when the patient presents to you, how will you differentiate that whether it's a ischemic or non-ischemic? So neovascularization is something which develops late, no? So you can't use as a point to differentiate the two. One thing you told is right, which is visual acuity. Then second thing you told, that's also right, that is RAPD. So anything else? So usually we say that there are 6 points which usually is suggested by Dr. S.S. Hare. So are you aware of the other 4?
Sir, optic disc involvement is optic disc edema is more seen in ischemic as compared to the non-ischemic central retinal vein occlusion.
It may be partly right, but exactly we don't use this as a point to differentiate the two.
Any electrophysiological test, ma?
Yes, ERG is used. So there is B wave reduction and reduction of B by A ratio in ischemic CRVO, which is not seen in non-ischemic CRVO.
Okay, good. Then
And
anything
FFA is also used to.
is one of the most important one because like based on FFA only we differentiate. What is the value that we say?
So more than 10 days diameters of capillary non-perfusion area should be there to say it's a.
Ma, again, as FFA, one thing, the patient comes fresh to you within 1 week. Would you like to go ahead and do the FFA right then and there and differentiate it based on the FMA?
No, sir. We cannot do it immediately because immediately when we do it will mainly show blocked fluorescence only due to all the hemorrhages. So we need to wait for some time.
Yeah, correct. Whatever you told was correct. So usually we wait for the retinal hemorrhages to come down because as you told, like the block fluorescence will obscure the areas of non-perfusion. Correct. Good. So what is that you see when you see the fundus? You can see clinical examination, whether is there anything which will help in differentiating the two. You see the fundus and what is the finding that you commonly see in CRVO? You see a case
Sir,
based on what?
so dilated and tortuous veins are there and flame-shaped hemorrhages.
Okay, dot and dot hemorrhages and flame-shaped hemorrhages.
Flame-shaped hemorrhages.
So if you go by like Sohan Singh Hare's article, so what is mentioned is like one is like visual acuity, then pupillary response, then fundus examination was like extensive retinal hemorrhages is in favor of an ischemic CRVO, though it's not a very important parameter. Then fluorescein angiography, then as you already mentioned ERG, and then one more is perimetry. Okay.
Perimetry.
The visual field, the perimetry, like it's significantly affected in ischemic central retinal vein occlusion. You now know the case. So will you still consider this case as ischemic CRVO? What all points are against ischemic CRVO now in this case?
So visual acuity is better. RAPD is not present.
Okay.
And the hemorrhages which we see are not that extensive as the picture of ischemic is seen.
True. Okay. So your diagnosis of would you now consider it as an ischemic? So in your differential diagnosis, can you rule out the chance of ischemic central retinal vein occlusion now?
Yes, sir.
Partly, but once you can fluorescein angiography and confirm that whether the non-perfusion is less than 10 disc areas, that will confirm that it is a non-ischemic central retinal vein occlusion. Since the hemorrhages are less in this case, you can actually consider a fluorescein angiography. Okay, but
Pradeep, just one point I would.
Yes, sir.
Yeah, Anjali, can a non-ischemic central retinal vein occlusion convert into ischemic?
Yes, sir. It can convert into ischemic.
Okay. So, at what point would you think that can happen, ma? So that is because of the follow-up of the patient. So, if it can convert, what is the time frame you are looking at, so that you can follow up the case for that long? The answer you have already told before. it's like 3 to 4 months, the 90-day thing, even a non-ischemic variant can convert to ischemic variant in 15% of the cases. So you should follow up so that they can develop any further complications, as you told.
Coming to investigation.
What Pradeep sir was trying to tell, ma, once you have all the things, so to write differential diagnosis as diagnosis is like, right, you have a differential diagnosis at the end, but a provisional diagnosis comes at the last. After having the differentials, you filter out all the differentials and write the provisional diagnosis. And in differential, you have ischemic here, and again in your provisional, you have non-ischemic. Both of the variants don't coexist together in the picture what you have shown.
Okay, sir.
And second, you have diabetic retinopathy. Like, can this be diabetic retinopathy? If it is so, like, which severity scale you would consider that would have all these features?
So moderate.
Okay, you mean to say like here hemorrhages are seen in all the 4 quadrants, that too extensive hemorrhages, that's what you told. You see venous tortuosity also. Okay. So if you see both, then what stage of diabetic retinopathy it would be?
Severe NPDR.
Okay, what does if it is severe, what are the things you say it is severe? To say it is severe, you have this 4-2-1 rule, right?
Yes, so hemorrhages in all 4 quadrants.
Okay.
And there is IRMA present in 1 quadrant, and
Okay.
And venous bleeding is seen in at least 2 of the quadrants.
Venous changes, venous bleeding and tortuosity in 2 quadrants. According to you, here there are 2 points, no? Like retinal hemorrhages are there in 4 quadrants. Then venous changes are there in 2 quadrants based on your description of your fundus. Correct? So what it will be? It will be severe or very severe?
It will be severe. It will come into very severe.
Yeah, because like, but in this again, if you are pretty much sure that other eye you can't see the fundus and even that eye has diabetic retinopathy, then probably you would still consider severe non-proliferative, very severe non-proliferative diabetic retinopathy. But will it present with a sudden vision loss of 1 week?
And there is one more differentiating point, ma. Will a diabetic retinopathy, how is the disc in this case?
Sir, it was mild hyperemic disc. Margins were obscured due to the hemorrhages.
Exactly, ma. So in a case of, as Pradeep sir was telling, one is visual loss, and with all the findings, how commonly we see disc, which is blurred margins disc edema in a diabetic retinopathy. Can that happen?
So disc involvement is very rare in diabetic. It comes in very later stages, or very rare in diabetic retinopathy.
It's not like that, ma. In diabetic also, there is an entity called diabetic papillopathy, wherein you can still have disc edema with a good visual acuity. So it can happen. So as Pradeep sir was telling, if you are not able to see the other eye fundus clearly, then your mentioning of diabetic retinopathy is okay. But what we are trying to tell is diabetic retinopathy along with disc edema is a rarer event than a central retinal vein occlusion with disc edema, which is more common. Okay? Yeah. Pradeep, yeah.
What about hypertensive retinopathy have mentioned? So what are your points in favor of or against hypertensive retinopathy?
So for favor, we have arteriolar attenuations present. So that is one thing which is there. And the point which is against is there are very less AV, there are no AV crossing changes in the patient that
No,
which
there
needs
should
to
be
be
AV crossing changes by now. Like the patient is hypertensive and has gone to a stage of developing central retinal vein occlusion, then there would be AV crossing changes. If you go to the diagram, like the photograph, probably you will definitely see. And yeah, what you need to understand is like a patient with hypertensive retinopathy has a higher risk of developing central retinal
Very
vein
true.
occlusion. It's
Very true.
not that hypertensive retinopathy is a separate entity and central retinal vein occlusion is a separate entity. In this case, the patient may have a hypertensive retinopathy on top of which now he has developed a central retinal vein occlusion. But hypertensive retinopathy alone resulting in vision loss, have you come across? Like it's just there is no vein occlusion, there is only hypertensive retinopathy and the vision loss has occurred. When do you come across such circumstances?
So you can have disc edema also in that entity.
You would have heard of grading of hypertensive retinopathy, no?
yes, sir.
So in which grades you can expect macular edema and disc edema and vision loss?
Grade 4.
So
Exactly.
in grade 4 you can expect. Okay. So like if you had no no venous tortuosity, if you had severe disc edema with macular edema, you had extensive cottonwool spots in this eye and in the other eye also you have all these features, then you could have considered that hypertensive retinopathy as a primary diagnosis. Okay. So grade 4 hypertensive retinopathy as a primary diagnosis. Okay. But when you are seeing these features like this very like minimal disc edema, mainly what findings you are seeing is hemorrhages in all the 4 quadrants and venous tortuosity and dilatation.
Okay.
So you would probably consider the current presentation what the patient has come to you is with a central retinal vein occlusion. If you could see other eye fundus, probably you would have had around grade 2 hypertensive retinopathy. It's quite possible in this case. Okay, what about ocular ischemic syndrome? How will you differentiate ocular ischemic syndrome from CRVO?
So there will be no tortuosity in ocular ischemic syndrome in the vessels as compared to CRVO. And
yeah, good. One point is correct. We mainly see venous dilatation. Tortuosity will be not much. Okay, then.
So we can differentiate it on the basis of fluorescein angiography finding that there will be patchy
No, first we
choroidal
talk
fill.
about clinical because we haven't gone into investigation. No, like clinically, how will you differentiate? What other points regarding hemorrhages? Is there any difference between the two? Regarding the distribution of hemorrhages, the location of hemorrhages.
The hemorrhages are distributed in mid-periphery in ocular ischemic syndrome, whereas it's variable distribution in CRVO.
Yeah, we usually say not commonly flame-shaped hemorrhages, dot hemorrhages in the mid-periphery. Dot and blot hemorrhages in the mid-periphery is what you see in ocular ischemic syndrome. Okay, fine. So with this in your mind, like how will you proceed further?
So I would like to conduct a panel of investigation for the patient.
So
what you want to do?
What panel? Yeah. Seriously. Yeah. What panel would you do?
So for blood investigation, I'd like to have a CBC with ESR, lipid profile, blood glucose, blood sugar levels with HB1AC, and CRP levels. And for imaging,
one second. So whenever you are describing, no, it's always good if you classify and explain. So it's one way of conveying the examiner that you know things properly. For example, you can say that my investigation will be directed towards two things. One is to identify the risk factor for the patient developing central retinal vein occlusion. That would be one direction I would be looking at. The second direction would be to establish the diagnosis and for the treatment. Okay. So if you classify to identify the risk factor, what all you are planning to do? What are the risk factors this patient already has, and what additional risk factors you want to rule out?
So hypertension and diabetes is already there, and we need to rule out hyperlipidemia.
Good. So you would do a lipid profile. Fine. Then.
And
what is the age of
you
the
wanted
patient?
To ask CBC and DSR. No, you told first CBC and DSR. Why you want to do CBC and DSR in this patient, and why CRP in this patient? What is the reason? What you are thinking, and how will it help you?
So CBC will also will give us an idea of hemoglobin levels. So anemia we can rule out. And
look, is anemia a risk factor for central retinal vein occlusion?
No, sir, it's not a risk factor, but retinopathy.
Why are you thinking so? It is a risk factor. So anemia is also a risk factor. See, CRVO, if it is occurring, like you would be aware of Virchow's triad, right?
Yes, sir.
So disturbance in any of these. So even anemia is a risk factor for CRVO, but particularly in younger patients. So in younger patients, we do see patients with anemia developing central retinal vein occlusion. Okay, so ESR you told. Why ESR? Okay, CBC only. In CBC, other than HB, you get more parameters also, no? So will they help you in identifying any risk factor?
So platelet count if...
Okay. Okay, one thing what I wanted to tell is, like, I may not do CBC and DSR in this case. Some may consider, but what I would probably tell you is, when you are telling something, you should know about it. You can say you can say that hyperviscosity is one of the risk factor for central retinal vein occlusion. When I do a CBC, I will know the hematocrit. I will know the whether there is hyperviscosity. Even we do come across patients, particularly chronic smokers with polycythemia, with high hematocrit, developing CRVO. I am not telling that they don't occur, but when you are telling something, you should be knowing that why you are telling that. Okay, if you are telling CBC, yeah, I am looking at anemia, I am looking at hyperviscosity, I am looking at polycythemia. Okay, these are all not common causes, these are rare causes. So always talk about common causes first, then you move on to all this. You told ESR CRP. Why?
So CRP is an inflammatory marker, so it will be increased if any vasculitis is there. Or
but will you consider that has one of the common diagnoses at this age group? You would not really consider it, right? So see, you can evaluate for everything. I don't say that you should not, but always look for common things. And if you think that, like, particularly, when do you evaluate for, like, extensively? So in a patient with central retinal vein occlusion, when do you evaluate extensively? So since you are telling other things like vasculitis and all, so when do you evaluate? In which situations?
sir, if patient's age is less than 50 years old and we see
young patient, okay, then,
and we don't find any other risk factors where, like, diabetes mellitus is not present, or hypertension is not there.
okay, which is other than hypertension and diabetes, he has one more risk factor. What is that? She has one more risk factor. What is that? So one of the most important risk factor is old age and arteriosclerosis.
That's why I asked the age of the patient, ma. Anjali, that's the reason why I asked the age. Yeah. Carry on, Pradeep. Yeah.
Yes, sir. And even if it's a bilateral simultaneous central retinal vein occlusion, again, even if it is elderly, probably we will have a low threshold for even extensive evaluation. So bilateral occlusions or multiple branch retinal vein occlusions, vein occlusions in young, these are the patients in which probably you would consider an extensive evaluation. Otherwise, you would probably look into the basic things, the common things first. So as you only mentioned, like age being one of the important risk factor, in old age, we really don't need to do a very extensive evaluation. We may be dealing with a case of vasculitis or a case of an antiphospholipid antibody syndrome. I am not telling that it's not possible, but they are rare. So we have to first evaluate for the more commoner things. Okay. So like one line of investigation is about identifying the risk factor. What is the intention of doing that?
So we can prevent further progression and prevent attack in another eye also.
It's not just the eye, even you can prevent stroke, you can prevent
Stroke
an
and
MI.
MI.
Okay. Yeah. So vein occlusion, like we always talk about that eye is a window to the body. So you identify a vein occlusion, you treat all these risk factors, control these risk factors, you may probably even be saving the patient from developing a stroke or an MI in future. So that's one of the most important thing you have to do. Even if you see probably a branch retinal vein occlusion which is involving only the nasal quadrant, the vision is perfectly fine, it is 6/6, still we would probably consider evaluating, because we know that there is something wrong happening in his body. That's why there is a vein occlusion. That something wrong, whatever is there, we have to identify, we have to treat them and prevent other things from happening, other problems from happening. Okay. Okay. Regarding ocular, what you will do? Sir,
So
anything you
OCT.
would like to add, sir? Ashok, sir?
Yeah, that's what here. As Pradeep, you have told, it should be specific. When the patient presented to you with a 65-year-old female, when the uh, risk factors of hypertension with diabetes both are there, so you should ideally, if you want to investigate in the systemic angle, I would like you to see, as Pradeep was telling, go first and see the hypertension part of it, because along with age, hypertension is one of the most common cause for a CRVO. So as you said again, in an young patient, you would go more in favor of the other investigations wherein when you don't have this and when you don't have these risk factors. So the first thing I would want you to investigate is the hypertension part, the diabetic part, and hyperlipidemia. Definitely, I would do that. So later on, so when you go to the exam, they would want you to investigate the most common causes first, later on coming to the uncommon causes. So that is what I would like to reinforce to you again. Yeah.
Yes, sir.
So ocular investigations?
So an OCT.
Okay. Why you would like to do an OCT?
So to get the macular edema and see how much the extent of macular edema is if we are seeing clinically.
Okay, one is to quantify. Okay, then what are the advantages of doing an OCT, or what are the advantages of having an OCT with you?
Uh,
So one is quantifying. You already know clinically that there is edema, correct? But how much edema is there? What is the thickness that you can get by OCT? That is one thing. What are the other things you would probably get information from OCT?
so we can also get about visual prognosis also can be if
True.
ISOS junction is disturbed, so the
Very good.
prognosis will be poor. Whereas
Yeah,
if it's not,
what you told is right. I agree. ISOS junction, like now we don't use that term. We use the term ellipsoid zone.
ellipsoid zone.
Yeah, but will you expect ellipsoid zone disruption within 1 week of symptom onset?
Not
True.
You won't expect, right? but there is something else you would probably see, and you will say that, okay, this patient has poor prognosis, even in early this one for prognostication. Have you heard of prominent middle limiting membrane anytime? Have you heard of the term prominent middle limiting membrane?
I think she is.
It's okay. It's fine. It's no. Don't worry that. Don't worry about that. But in an early, like OCT, whenever you do, one thing is quantification. Second is prognostication. Third is follow-up. You always keep these three in mind. Any disease, if you are dealing with AMD also, it's fine. If it's diabetic retinopathy, macular hole, take anything. You keep these three things in mind. One is to document and quantify. Second is to prognosticate. Third is to follow up. Correct? So you just remember these three things, and according to the situation, you speak about it. If you are dealing with a case of a vein occlusion which was almost like 3-month-old, 4-month-old, maybe, as you told, the integrity of the ellipsoid zone, external limiting membrane were the prognostic factors at that time.
Very true.
In an acute setting, probably you would not expect those. You would probably expect, if it's an ischemic central retinal vein occlusion, or if there was a significant ischemia, then you would see a hyperreflective line which is described as prominent middle limiting membrane. Okay, so if that, if you see something like that, then you would assume that, okay, the prognosis is poor, the chances of visual improvement will be lesser. Okay, the third thing, as I already mentioned, it's about follow-up. Once you treat the patient, how is the patient responding? So it's not just to this case. Any case, whenever you are thinking about OCT, if someone says like, why you are doing OCT, you keep these three things in mind. Okay?
Yeah, Pradeep, I think it's already 8:30, so we can just ask her.
Treatment.
Okay, so first we need to control the systemic factors like hypertension and diabetes. And for macular edema, anti-VEGF injections or intravitreal steroids can be given to the patient.
Okay, what is preferred? Whether you prefer intravitreal steroid first, or will you prefer intravitreal anti-VEGF?
So first we'll prefer intravitreal VEGF.
Okay, anti-VEGF. Okay.
Anti-VEGF injections. And
so is there any particular anti-VEGF which you would like to choose, ma? Out of the, so can you elaborate what all anti-VEGF injections which are there, and which would you like to?
So bevacizumab is there, ranibizumab and aflibercept is there. These three are available for intravitreal injection. So out of these three, aflibercept is the one which has efficacy against VEGF A, B, and PIGF. So if out of these three, if we want to prefer, aflibercept is the best, but it also depends upon the patient what they.
It's better not to jump to say that it is the best, actually. Okay. So most of the times when we speak about comparison between different anti-VEGF, you should have some evidence to say that this is the best. Theoretically, I agree that it has affinity. It neutralizes more pro-angiogenic factors, but that doesn't mean that the clinical effect, the clinical efficacy, like what we are finally worried about is whether the patient will gain vision or not. That is the most important thing. If that is being served by any of these drugs, you should not just directly jump to a conclusion saying that this is the best. Okay, so don't take such don't make such statements in your exams. Okay, and then someone may ask, are you aware of any studies comparing ranibizumab versus aflibercept in CRVO?
I was about to ask that only, Pradeep. The next question was that, are there any studies she has Yeah. Carry on, Pradeep. Yeah.
Yes, sir. So don't jump to such statements in your exams, okay? You told 3 anti-VEGFs. Read about other anti-VEGFs which are already available in the market. So please read about them also. Okay, so like you told the treatment of macular edema is anti-VEGF. Then you treat macular edema. How often you follow up the patient?
So we initially follow up for each month for first 6 months.
It depends. So this, I think, will not stretch it more, but you should be knowing a few things. I will just tell what you need to know. Some people follow a loading dose followed by fixed interval, and most of the people in Southeast Asian countries in India follow up PRN based treatment, that is pro-re nata. Pro-re nata stands for it means as and when required. So we usually follow up the patient every month. If there is macular edema, we give an intravitreal anti-VEGF. What other complications can develop in future in this patient?
So they can be neovascular glaucoma. They can be a formation of ERM, vitreous hemorrhage, and retinal detachments.
What kind of retinal detachment?
So tractional retinal detachment.
Okay, so over time, what all things can happen because of the ischemia? Patient can develop neovascularization, which can result in vitreous hemorrhage, formation of fibrovascular proliferation, which can result in traction retinal detachment. If the traction worsens significantly, it may create a break and even a combined retinal detachment.
Okay.
If a neovascularization of the iris develops or neovascularization of the angle develops, neovascular glaucoma. So all these things are possible. Okay.
Yeah. I think it's time, Pradeep. Should we?
Yes, sir. Yes, sir. Yes, sir.
It's 8:37. Anything more to add, Pradeep, or?
No, I think it's. I think we can wrap it up, sir.
Yeah. So Anjali, it has been a nice presentation, ma. You've known things nicely. It's only that this is just a point of presentation wherein we try to tell you what to present, the format or like the sequence what you should know to present. So things you know in a haphazard way, we are trying to just streamline that and put it into perspective. That is what we have done. So I think overall, I think it's a nice presentation, Anjali, and very well moderated by Dr. Pradeep also.
Thank you so much, sir. And it was very well moderated by you also, sir. And it was a nice presentation. Good, Dr. Anjil. A few things which you have to always keep in your mind is examination. If learning for the clinical experience and for your practice is more important, we agree. At the same time, you also have to do this case presentation for the exam purpose, so that everyone agrees that for the exam purpose you should know this. So whenever you are speaking, always speak about things you know. Don't
Pradeep, there's a
unnecessarily.
question by Dr. Sajal Jain. It's been there in the chat box. Will the type of hemorrhages in diabetic retinopathy be different from CRVO? There's a question. So, Anjali, can you say the differences between how the hemorrhages in a diabetic retinopathy look like and differentiate?
So in diabetic retinopathy, the hemorrhages are mainly distributed in the posterior pole.
Okay.
Rather than, and in CRVO, the hemorrhages most commonly are flame-shaped hemorrhages, and
Truma.
If it's diabetic retinopathy, we'll see other changes like hard exudates will be present, and this will also help in differentiating.
regarding the type of hemorrhage, what is more common in diabetic retinopathy?
Dot and blot hemorrhages are more common in diabetic retinopathy, whereas
Very true. Very true.
flame shaped is
Yeah.
more common in CRVO.
Correct.
Correct.
So if there are no questions from the audience, I think should we wrap up the session? Okay then.